Well, I think we can get started there's a little movement there. I think I can share the presentation and do some basic introductions out of respect to everyone's time, and that way we can have more time for Q&A at the end. Greetings, everyone. This is Dr. Rodolfo Oviedo. I'm here in Nacogdoches, Texas, USA. It is my honor and my pleasure to introduce everyone today and welcome you to this webinar for SAGES, the Society of American Gastrointestinal Endoscopic Surgeons, on behalf of the RAFT Committee. RAFT stands for Residents and Fellows Training Committee. And I'm here with my co-moderator. It's an honor and privilege to share the podium with her, Dr. Micaela Esquivel. Dr. Esquivel, how are you?
Wonderful. Thanks so much, Rodolfo, for helping organize a great panel speaker here. We have three amazing speakers. I'm a minimally invasive bariatric and endoscopic surgeon out of Stanford, did all of my general surgery fellowship training and now faculty at Stanford, so quickly becoming a lifer. I'll let Rodolfo kind of do the rest of the introduction slides that we have, and then I think we can get started with Manuel.
Thank you, Micaela. So everyone, please welcome Dr. Esquivel. Micaela is a board-certified fellowship-trained bariatric foregut minimally invasive surgeon. She has won many accolades throughout her illustrious career. She's a rising star. She's an associate professor of surgery, a clinical associate professor of surgery at Stanford University School of Medicine. She also directs the Service Through Surgery Surgeons with an Impact course at Stanford University School of Medicine. She is the co-chair of the Stanford Department of Surgery Diversity Cabinet. She has lectured at multiple congresses and meetings. She has written at numerous journals. But the first time I met her I already knew about her, but I had the honor of meeting her at SAGES 2025 in California. And during spring break, and it was a phenomenal experience. I attended her lecture, and it was the bariatric endoscopy lecture. And the three lecturers that we have for you today, this is a treat. These are world-class experts, and it's an honor for us to welcome them here. So if you give me a few minutes, I would like to start with a very brief presentation on behalf of SAGES. It's just going to take 5 slides or so. Allow me. I'm going to share my screen. Can everyone see my screen?
Yes, looks great.
Yes? Okay, great. So this is a SAGES webinar, and the title is Endobariatric Alternatives to Roux-en-Y Gastric Bypass. We have today Dr. Manuel Galvao Neto, Dr. Adarsh Thaker, and Dr. Brandon VanderWel, and we, of course, will be introducing the faculty for you. The schedule is going to look like this. We're going to begin with the intragastric balloons talk with Dr. Manuel Galvao Neto. Then we'll follow with duodenal mucosal resurfacing with Dr. Thaker, and then we'll follow with ESG with Dr. VanderWel. And on behalf of SAGES, this is a wonderful society. We encourage everyone to join. Membership is extremely precious. It has given us so many benefits throughout the years for those of us who joined from the time when we were residents. And it's one of those societies in the world that are authority societies, and people tend to stay. They don't go anywhere. They stay within the society, and they develop their careers around the multiple committees where they can serve and they can occupy leadership positions down the road. It's a society that awards its members based on merit. It's truly based on your energy, your dynamic impetus, and how much effort you put into it and how much you want to serve. I encourage everyone to join. At the same time, the vision of SAGES is reimagining surgical care for a healthier world. The mission is to innovate, to educate, and collaborate to improve patient care. And of course, you can see the values: inclusivity, innovation, service, excellence, and global community. And of course, unofficially, fun is one of the values of SAGES, and we know that for sure. We know how to have fun with friends. The membership benefits are numerous. Of course, you can get substantial registration discounts to the SAGES annual meeting, which is one of the most important surgical meetings in the world. You can get cutting-edge education, professional development. You can get webinars like this one. You can get resident and fellow courses. You can get online learning. The sky is not even the limit for SAGES. You can access a network of more than 7,000 colleagues and friends and surgical endoscopy experts, such as the faculty who are here with us today, donating their precious time and expertise. And of course, you can get access to SAGES social media groups and platforms. online subscription to one of the top surgical journals in the world, Surgical Endoscopy. We all respect it and admire it, and we serve as reviewers. Also, you can get members-only research grants, which are substantial, and career development awards. And finally, numerous involvement and leadership opportunities via committees, task forces, and peer reviews. So I think this is it. One more thing. There are 3 categories for membership. We encourage everyone to become members based on their level of expertise and education. Active members for surgeons in Canada and the United States of America. You can become a candidate member for residents or those enrolled in fellowship programs, or medical student members. And of course, we have international members. We welcome all international members. So this is just something simple, and I'm going to stop talking. It's too much. And now it's the time to introduce our first speaker. And Micaela, please, you have the honor of introducing our first one. Now I can say a few words as well, because he needs no introduction, but we need to do it formally.
Yes, so very excited to welcome Manuel Galvao Neto, a surgeon, an endoscopic surgeon out of Brazil, earned his master's degree in Sao Paulo University, medical training in Bahia School of Medicine in Bahia, Brazil. And then Dr. Galvao then completed his residency in GI surgery as well as endoscopic surgery in Sao Paulo, Brazil. So has really been a leader in the field of surgical endoscopy for many decades. We were actually just visiting about his expertise before this, and honestly, it's really is a privilege to have him here speaking, because truly has been a leader on all fronts, on all topics actually that are being discussed today. And currently a leader at Orlando Health. And so we'll be closer to him, SAGES, this coming year in Tampa in 2026. And please, Rodolfo, add anything that you would like.
And just a few bullet points from a moderator point of view. Each speaker today, each distinguished speaker will have 20 minutes for the presentation. We encourage all of our participants to please utilize the Q&A box underneath on Zoom. You can see that Q&A box. If you have any questions for the speakers, we'll be happy to verbalize them. Now, if you do not have a question, if you just have a comment, congratulations, gratitude comments, greetings, please type them in the chat box. But if it's a question, go to Q&A. We will ask some questions at the end of each talk, but if it's too many questions, and we welcome all of them, we'll ask the rest of them at the end during the general Q&A session when the 3 speakers have had a chance to speak. And having said that, my esteemed friend, Manuel, the podium is yours. Welcome.
Thank you very much. Thank you very much, Micaela, for the kind words. Thank you very much, my friend Rodolfo. And no further delay, I will share my pack of slides. And I hope you can see my presentation right now. If not, just let me know. So yes, now, thank you. I'm in US now for 1.5 years. In Orlando Health with this beautiful team that is on your screen under the leadership of André Teixeira, Hani Thaker, Mohammad Jawad, Mohammad Ghana, and our obesity medicine, Dr. Daniel Kittner. Also to know that we have a very strong academic collaboration with India and EARCAT India and Mohawk Bariatric Center. So we circle in and out with regarding of the trials that we're doing here. Those are my conflicts of interest. I offer you to judge if this presentation will be commercial or not. So the whole idea of this presentation is to get back to old fellow, the intragastric balloon, and to see if there's still an option in the endobariatric therapy or obesity treatment as well. And let's gather what we have. So just in front of you, you see how beautifully expand we have now the bariatric and metabolic endoscopy. So we have devices that occupy space in the stomach. We have the opportunity of remodel. You're going to see one of the presentation, the anatomy of the stomach by means of endoscopic suture, endoscopic plications. We can detour the path of the food. We can remodel mucosa and of the duodenal and the distal part of the bowl as well. So have plenty, a plethora of procedures. But let's go back to what was the very, very, very first endobariatric procedures. That is the intragastric balloon. And it, for a long time, it was the entry level to effectively treat obesity. Because when it started, obesity medicines, they were not really there competing of what we are doing. So we are really doing that for long. So you can see here how it goes. On the upper part is the traditional balloon, saline filled, 400 to 700 cc. And then there was these balloons that was a nitrogen filled balloon. Each week you take one of these, and up around 4 or 5 months you have to remove by endoscopy. On the right side of the screen, I hope you can see my arrow, you see this here that they were all approved by the FDA. It's called intermittent obstruction of the pylorus. On that direction, on the bottom part, at the left part, you're gonna see the adjustable gastric balloon that allows a saline solution to be put in and out, or to add extra weight loss, or to downsize it if the patients have adaptation problems. And at the very bottom on the right, you have the swallowable balloon that is currently under investigation. That said, even with those balloons approved, they are out of the market due to issues with the companies that develop them on the direction, besides being FDA approved. So let's talk about what is a balloon. Generally, something that you pass through the mouth. You're gonna fill that in the stomach with liquid, gas, or air. You're gonna stay there for a while, and it accomplishes your mission. Mission that is not allowed food to pass. So patients are gonna have satiety, early satiety, is induced weight loss. When it fills its time, complete time, you're gonna go there, puncture, empty, at the level that you can grab it with a grasper and remove it throughout the esophagus. So basically is what this traditional liquid filled balloon they are. So to illustrate you more, I'm gonna pass a quick video, and this is a very special video that was done in 2015, but it was the video that it was trained all the surgeons in US at that time, and endoscopy. So you can see here, we don't do intubation, it's just sedation. You pass through the mouth, so you follow the path of the trough, and you go there just after you pass your scope to confirm that you are in the stomach. And you see here, you're gonna fix your scope, looking at the balloon, the valve of the balloon. You can check if it is distally well positioned. So you got both. You're gonna remove this wire. So actually, this specific balloon don't have this wire anymore, but they still have the filling system that is a one-way valve. So it's connected to a saline solution. You're gonna do suction. And when you inject this, you're gonna inject it direct into balloon until you break up a silicone cocoon that is there. So all over the world, it is a saline solution with methylene blue. Here in US, by FDA request, it was without methylene blue, so it's an off-label use for that. And you can see here in the direct vision, you're gonna put there, and it's between 400 to 700 cc. It is not really advisable unless the patient is a teenager or a kid to do less than 500 in that direction. So you can see here we're checking just after 200, 250 cc's, you can just pass the scope and check that. And now it's at the end, and you're gonna see here that we are doing retrovision, and you can see now that we're gonna protect the esophagus with the scope on that, and we're gonna detach the catheter, so the valve is auto-sealed, and you're gonna see that you will inspect that is any leak or that is very, very unusual. So for sure, you have to test your balloon, and you have to do a retrovision, see if you stay in the gastric fundus with the antrum free on that direction. And then the procedure is done, patient can go home the same day. And time comes, you're gonna get to removal. So specifically for this balloon, is a FDA balloon approved. You have a special kit to do that. That consists in a needle and a double hook grasper in that direction. So this is time passes, so you're gonna do that. We recommend that you do that with a patient intubated, because always can have food on the stomach, because it's a foreign body. So you can see here for retrovision, and interestingly, YouTube's plenty of videos that they do the puncture in the retrovision. I don't advise you to do that. because the balloon gonna push the balloon, is gonna be unstable. So the best way is understand the balloon where it is, do the suction, take all of the fluid, and then corner the balloon, and then puncture the balloon. Once you puncture the balloon, you're gonna remove the needle that is inside with a catheter, and you can start doing the suction of the balloon. Don't get attached of how many you have put initially. Just be aware and attached that the end of the suction, the liquid of the balloon, have to be a very thin border, as you can see it right now. So this means that you can remove the catheter. So take the vacuum, otherwise you can stretch this needle, and then it's there. It's a single channel scope in the direction. You can do double channels, more fancy, because you can stabilize balloon with a grasper. But generally, you just go there with this double hook. That, to acquire the balloon, is the best way to do a retrovision. The catheter have to be passed outside, otherwise you can damage your scope. So grab it, pull against the scope. I used to joke that you should not be seeing anything. So put it very attached to the tip of the scope. And once you get into the esophageal junction, start negotiating the passage, and you're gonna feel it and the balloon passing until we remove that. And then you have to go back with your scope to check if there's no damage on the areas that the balloon passed through. So we have published an alternative technique on endoscopy that you can use. I really recommend, because it's much easier to do on that direction. So gastroscope, use the Raptor grasper from Steris, and needle aspirated and canola oil. And if your system allowed you to, you can use also mineral oil or even olive oil. So you can see this is a balloon with methylene blue, how it is 6 months after. So punction is pretty much the same. So we prefer not to use
concave shape. That is removed. After that, we can access with the same catheter and apply 50 catheter.
Not to use that. So we're gonna put some oil after you finish that
around the balloon, stomach, and also is to decrease the friction between the balloon and the stomach Raptor grasper.
So this is the Raptor. Why you like the Raptor grasper?
In place
because the double hook can be cumbersome, can get engaged into your scope, can get attached to the tissue, can do some damage. And the rupture point we measure on the lab is the same.
Of friction between
so
the
you can see here how easy
the
balloon with the oil and the grasper can go. So you're gonna see in the literature there is no alternatives to do that. Then we have the adjustable balloon. So you pass alongside the scope, you don't introduce that, and then you inflate that. The major advantage of this balloon, as you can see here, is during any time you can go there, have a tail, you grab the tail, get out to the mouth, and you can adjust to plus or minus. So you can adapt plus with intention to more weight loss, and minus if your patient are having symptoms like vomiting or pain or too much nausea in that direction. And more recently, that's under investigation in US, you have the swallow balloon. So you don't need endoscopy to put it in, you don't need endoscopy to put it out. So you pass through the mouth, you do an X-ray to see it's there, you inflate it, another X-ray to see if it's really inflated, you detach the balloon. This stays just for 4 months. And you can see here, when it got the time, they have a weak spot that are gonna be open. And this is not made by silicone, it's a polyurethane, very thin film that they're gonna empty, gonna pass through the bowl. So no endoscopy to put it in, no endoscopy to take it out. So what we have approved by FDA is a balloon called Orbera, that's now made by Boston Scientific, and it's a liquid filled balloon. And we have the SPAS balloon, that is the adjustable balloon. And those both have FDA randomized trial that put that on the market. And the swallow balloon is now on the second trial of the FDA, and I think they submitted to the FDA. We're gonna soon learn if they got approved or not on that direction. So how about data? It's a long time on that direction. So I'm gonna start with real life data. So what real life can give to you, I'll present the Brazilian consensus of intragastric balloon. It's very important consensus-wise real life, because it's about 41,186 cases. for 35 participants, all of them with at least 300 cases done, very experienced crowd on that direction. And all of them were board certified on that. And we voted during 3 days on the systematic way to get to the consensus that we have. But we're not going to go to the consensus itself because it's very, very thick material. But what I can tell you, a snapshot, that in the real life, you can get it that. So a mean of 18.4% of total body weight loss, adverse events of 2.53%, and the most common hyperinflation or hyperinflation of the balloon leading to its removal, or spontaneous deflation that sometimes can lead to migration of the balloon. So we have an early removal rate of 2.22, and we have mortality of 3 patients out of 40,000. So it's really, really, really low mortality to those numbers on the directions. So you can see here in the real life, you can reach 15 to 20% very predictably on that direction. But when you're going to go to controlled trials with meta-analysis, it's way less. So the first meta-analysis we heard about it is this one that we took part at São Paulo University. And believe me, my friends, it's a meta-analysis of randomized trials. So at that time, we get to use the very older balloons and the new one that is the liquid filled, 9 randomized trial, 700 patients, and we measure weight loss, and you can see here that is the structure of the meta-analysis on the direction. For the left side of the graph, it benefits the balloon. For the right side, it benefits the control group. So you can see here that really was significant more weight loss on the balloon groups on all the studies when compared with the control groups on the direction. But you can see here that during trials, the weight loss is not that good as real life, that they can be between 5 and 10% of the weight loss. So newer meta-analysis with more and better randomized trials done. So again, is a meta-analysis of randomized trial, and then including newer balloons like the swallow balloon, like the adjustable balloon, again done by University of São Paulo. And you can see here that again, this very well done meta-analysis, including all the studies published at that, and we jump from 2016 to 2020 on that, and 13 papers on that direction. And you can see here that the percentage of total body weight loss now is for the right side, benefits the balloon. And you can see here that they go around 5 with the older balloons, but you get the newer balloons. For example, the adjustable balloon is around 18% total body weight loss. Sorry, 16% total body weight loss. So really better design balloons, better design trials can get near to what we see in real life. And you can go and Google now about intragastric balloon, you're gonna see tens of thousands of literature published about that. So it was really trial by fire in academic way, so you have that. So you can see here that the new meta-analysis go near to the 15% that we need to be in the balloon. So that's balloons, the very first to start. Just take a look at the screen. So this is me, 30 years later, performing balloons. It's a lot of time. And interestingly, we used to say this for 2020, but now it's 30. So I feel the age on my shoulders just saying that. Now we have a big, big challenge. That is the entry level is now the very effective GLP-1 analogs. So everything is like blurry with the real overlap of indications between different methods, endoscopy, basic medicine, and even surgery. So we have to debate on that. And really, balloon is on jeopardy, especially in the US, because the price is like much more than outside the United States. So the price is near for endoscopic gastroplasty, near that even a surgery. So the price position is a cash pay model. It's not putting that on the direction. So the market is down on that side, but look at that. So I went to the research And the market value in 2023 was around $120 to $150 million. And the projected growth rate of the compound annual growth rate, more specifically, is around 10 to 12% the next 5 years. It's not that much, but it's still growing. And by 2030, we expect a market of around $300 million worldwide on that direction, specifically if it picks up in the US. And when we see a problem, also we can see opportunity. So how about balloons for fatty liver? So this very small trial, but very effective trial done in Mayo Clinic by Bahama Budaye, at that time he was there. And he used the same patients as control because they did endosonography biopsies of the liver before and after, so the patient's control for himself. And you can see here that after the balloon, the steatosis, the ballooning of the hepatic cells and the inflammation, they were all down at a level that it is now approved by the FDA to use balloons to, and it was the first method to be approved, then comes the medicine, to temporarily control the fatty liver in a very efficacious way. So how about combination therapy? Is on the topic right now. We anticipate a little bit, so I can present to you from our services that at that time were in Brazil, adjustable balloon plus liraglutide. So this trial, in a case match, is a very elegant way to present a retrospective series. So this is like this. So we have patients that just the balloon and then remove the balloon and just multidisciplinary team support follow-up. And there were patients that was the balloon removal and start liraglutide, that is one of the first and less powerful GLP-1 analogs. So what we can see here in the two graphs is that in blue, we have the balloon with liraglutide after the removal, and you can see that they keep the weight that they lost. And if you go to the right side, you can see the yellow, the group that didn't have it, they regain weight significantly in the direction. Also, how about concomitant use? So this is a work we did in India, and it's published in Obesity Series, a randomized trial that we put, there was a group just with a swallowable balloon for 4 months, and then swallowable balloon plus oral semaglutide. You're gonna see the real difference, almost 17.6 against 13.7. So significant difference in the direction. So there's a lot of studies on that direction. And finally, we got a CPT code in 2023, and it's a slow pace, but we have a CPT code that it opened up the window that we can be reimbursed for the balloon, so the cost of the balloon can be covered by insurance, so that it can change everything in how the balloons is used in US. So thank you very much.
Manuel, thank you so much. Let's see, Rodolfo, I don't see any questions in the Q&A. But again, thank you so much for your talk and just sharing your expertise for the last 3 decades of using balloons, essentially. And so just to start off some of the questions, my question to you is, so what is in your practice now, let's say you're placing a balloon on a patient, what follow-up and surveillance do you have while the balloon is in, right, for that 6-month or so period? And then what does your follow-up and surveillance look like afterwards, and how has that impacted your patient base and their outcomes?
Absolutely. So I'll talk about US, so because we are here with our audience. So during the 6 months, we have the pre-consultation, the multidisciplinary team support, and at least once a month, the patient will get back with us. And nowadays, most of them, it is virtual on the direction. And we got to the month 6, we start preparing our patients when the tool will come out. So to avoid the rebound, we offer the patient a more intensive multidisciplinary team support with continuous up to 1 year at least, with once a month consultation, but more than that, we combine with our obesity medicine. You don't have to be the most expensive and the more newer GLP-1 analog, but you can start with liraglutide just after that. And it's amazing how we can keep the weight for 1 year or more. And if you reach 1 year, so the possibility of the patients keep the weight for more time. This is a study done in Japan that they follow the patient for 10 years. So if you get 1 year and don't rebound the weight, and the possibility of keep that for 3 or 4 years is much higher on that direction. So you know that it's gonna happen, the rebound, the weight regain. So we prepare for that. So that's the most critical part, is when you're about to remove the balloon on that direction. Also have to be very cautious in US to consult about the diets, because diet is something very keen to the Americans, and they don't like us to mess with that. So I might, if you are beginning, my advice is sit with your patient, sit one time more than you think you should, to go through the diet and follow up on that direction. And you're gonna say, why I need to do a diet? Because if I have the balloon, it's your tool. Take good care of that.
Absolutely. Thank you for sharing that.
Thank you, my friend Manuel. It's been an enlightening talk, and I know there's so much more that we can discuss at the Q&A session, but let me ask you a question. And by the way, to those who have joined us later, Manuel is a dear friend. He's one of the fathers of bariatric endoscopy. He's young, but at the same time, he's been doing this for decades, and we can learn a lot from him. He's also a professor of gastroenterology and surgery at Sri Aurobindo Institute in India. And he's a visiting professor at multiple institutions, including a Mayo Clinic and also in Hong Kong. So a question for you, Manuel. If you were to teach residents or fellows watching us now, what is it that you like about the balloon? So what do you tell your patients? What's the beauty or the advantage of the balloon? And what is the Achilles heel of the balloon, whether technical or follow-up or weight loss, etc.?
No, that's a good one. So technically, for the residents, it's a nice procedure. They love to do it. It's where you develop a lot the endoscopic skills to put it in, to take it out. So it's a foreign hind body removal. So you can acquire a lot of finesse on the skill set. The Achilles heel is the complication. So we are dealing with a prosthesis. So our body is perfect. Nothing inside, mark my words, nothing inside the stomach survived the stomach. If it survived, it's gonna cause damage. So it's a matter of equation on how long it's gonna stay safe in the direction. So the complications, so you can have the balloon emptying and going obstructing downstream. You can have ulcers, specifically like the adjustable balloon have a tail, so patients have pain. Don't be shy, bring back, look at that. Most of the time you can really keep the balloon if you got it on that direction. So many of the complications must be there. You need a very good training on endoscopy to do that. Sometimes you have a colonization of fungus and the balloon get corroded, so it's more like fragile on removal on that direction. And I say that the Achilles heel is that it needs attention. It needs follow-up. Any foreign hind body on the bowel needs good follow-up. You cannot send the patients to the woods. It's your duty, it's your obligation, your responsibility to follow these patients.
Great, thank you. And we have a question from one of the participants, Ahmed Jad, asking you, what are the post-procedure instructions after balloon that you give patients before they go home, so the day of the procedure? And what were the 3 cases of mortality that were related to the balloon in the studies that you mentioned?
Okay, that's a good one. So medications to mitigate the symptoms. So we're gonna have a critical period of 5 days. And it's gonna be a love and hate. Patients are gonna hate you because of the symptoms. They're gonna love the weight loss. So one good thing, if your system allowed, is put the balloon in 2 days after, bring your patient and hydrate, because they have problems hydrate. I see that in US. OUS is a little bit easier, but here, if you just put them back and hydrate, half of your problems are gone. But medications is aprepitant. Aprepitant is 20 times more powerful than Zofran. So you cannot vomit. You can have some nausea on the direction. Painkillers, no, but you can go with an an NSAID on that direction. Scopolamine patch is a double sword because the stomach can get bigger on that direction, but most of services put a scopolamine patch as well in that direction. And also, don't forget about how is the name of the drug we put for motion sickness for the kids? That drug is fantastic because it prevents nausea, but it sedates your patient a little bit more. So
Dramamine?
Dramamine, yes.
Yeah.
So that's Manuel trick for you guys. That's Manuel. Hydration and Dramamine. That's my trick for you guys. And with that, because remember, you have an adaptation period of 5 days. If you really do well on this post-operative, you're going to reduce to 3 days and less. And after that, 7 days, the stomach settles. After 7 days, your patient keep complaining, bring him back. It's not right.
Thank you so much, Manuel. We're going to continue, and I'm sure we'll have more questions to discuss with you at the end. And just a little more about the next speaker. I'd like to introduce the next speaker. Thank you very much, Manuel. And please hang out with us until the end if you can.
We'll be here.
Thank you, thank you. And once again, I want to welcome everyone joining us. This is Dr. Rodolfo Oviedo. I serve as clinical professor of surgery at the University of Houston in Houston, Texas, and at Sam Houston State University at Conroe, Texas, USA. And I'm the director of bariatrics and robotics at Nacogdoches Medical Center in Texas. And I'm here co-moderating and co-hosting with Dr. Micaela Esquivel, who's an associate professor at Stanford University. It is our honor and pleasure to now introduce the next speaker. And just as a reminder to all the speakers, when the speakers are giving their lecture for 20 minutes, let's make sure that we turn off the camera, not only the microphone. That way, all the attention is on the speakers. And the next speaker is, this is quite a treat to have him here with us. I also had the pleasure of meeting him in person at SAGES 2025 in California. It was a phenomenal lecture, and we invited him to give the same lecture here because we believe that it has tremendous value for all the learners and participants. Dr. Adarsh Thaker is an interventional gastroenterologist with particular interest in bariatric and metabolic endoscopy, and also in minimally invasive and advanced endoscopic procedures such as ERCP, EUS, etc. He completed a medical school at New York Medical College, and he did residency in internal medicine at Beth Israel Deaconess Medical Center in Boston. He did gastroenterology and advanced endoscopy fellowships at UCLA in Los Angeles. So it's our honor, our pleasure to host him. And today he's going to be discussing duodenal mucosal resurfacing. So is it something that is worth learning about? Is it a dream? Is it a reality? Let's do it. Welcome.
Thank you so much. Thank you to Dr. Oviedo, Dr. Esquivel for inviting me to be part of this great panel and to have this audience. I think, as you mentioned, I'm an interventional gastroenterologist, so not a surgeon, but increasingly a lot of the procedures that we do in therapeutic endoscopy are bridging the gap towards surgery. And at UCLA, we are constantly working with our surgeons to come up with creative solutions to various disease states. So to me, it's not about what your training was or what kind of skills you may have. It's really about problem solving and figuring out how to best treat the disease in front of you rather than kind of working in silos. And so this field is quite interesting to me for a couple of reasons. One of them is that many of the clinical trialists that I work with around the country are actually surgeons that are performing these procedures as well. So even though it's endoscopic, I think there's already early interest among surgeons. And then I remember, I was waiting to start my talk at SAGES, where it was also an honor to speak just a couple months ago. And I remember chatting with Dr. Esquivel afterwards, but kind of just reflecting on the treatment for diabetes. And it's near and dear to my heart because a lot of people in my family have diabetes, and we don't have a lot of obesity. It's really kind of just, they say the Indians have our fat on the inside, I guess, or, in the blood vessels or wherever it might be. But in the 40s, just out of nowhere, a lot of people. And I remember when I was young, as a kid, I remember my parents would imprint on me, oh yeah, Adarsh is going to become a physician one day. And because of that, they would help me prepare or have me pretend to prepare the insulin injections that my grandma would give herself. And my late grandmother now, but that was, you know, in the 80s and 90s when I grew up. I remember her injecting herself with insulin. And fast forward now, several decades later, and when you think about how we treat diabetes in this country, not that much has actually changed. You know, there's more medical agents out there. So, you know, you have all the different classes of oral medications, there's injectables, and if people are still refractory, you may still use insulin. It's really the same kind of algorithm. And there's arguments about stepping up versus stepping down and those types of endocrinology protocols. But really, we are chasing the glycemic control rather than addressing the root cause of disease. And for that reason, I think that this is a fascinating topic, and we may be able to kind of, I think what we're learning is that we can do the therapy and still learn after the fact why it works. And so with that kind of background, I'll start talking about duodenal mucosal resurfacing, or recellularization, as people are starting to call it, and its evaluation as both a metabolic and a weight loss treatment. Here are my disclosures. A couple that I will point out that will be relevant for this talk is that Fractal and Endogenics are both two of the front-running companies in this field. And from just experience and also just giving very frank feedback, they both asked me to help out with the movement. So I do kind of work with both of them. Metabolic endoscopy is predicated upon the idea that diabetes and obesity and other metabolic conditions are diseases of the gut. And when you take a closer look at the gut, it is a complex, integrated, hormone-dependent metabolic network. And it really is the ringleader or the pilot of this complex aircraft that controls all of metabolic controls your metabolism, really. So it's kind of the ringleader, it's the flight deck, and it's not just simple kind of mechanisms. There's a variety of ways that the duodenum, and particularly the proximal jejunum and the duodenum, can exert its effect on the metabolism of your body. And bariatric surgeons have known about this for decades. And so, you know, this is a systematic review and meta-analysis of 22,000 patients from 2004. This is old news. And we know that bariatric surgery, particularly Roux-en-Y gastric bypass, can essentially improve or resolve glycemic imbalances in patients independent of weight loss. And you could see these outstanding numbers: complete resolution of diabetes in nearly 77% of patients, and improvement in the vast majority of patients. And again, we see this even before the patient may lose weight. You know, I remember hearing stories from some of my bariatric surgeons of patients with diabetes whose blood sugars are essentially normalized before they even leave the hospital post-operatively. So it's long been known that this area, the foregut, is really an important control mechanism for diabetes. And why is gastric bypass such a great metabolic surgery? Well, in the old days, you know, the classic thinking was that there's a restrictive component, there's a malabsorptive component, and we know now that that's an oversimplification and outdated thinking. There's a variety of theories out there, including the rate of nutrient distribution to the hindgut. There's theories about bile acids, microbiome abnormalities, what we call dysbiosis. But I'd like to kind of hone in on one that we've observed as it becomes relevant to duodenal treatments, and that's the mucosal abnormality hypothesis. And what this says, or what the hypothesis is that prolonged exposure to an unhealthy diet, as we often have here, particularly in the US, prolonged exposure to this type of diet leads to increased mucosal changes in the proximal small intestine. And the gut, as a result of these changes in the prolonged exposure, may produce counter-regulatory signals to balance the action of excess insulin that's working to kind of counteract the diet. So high carb, high fat diet, you have excess insulin, and the gut may produce anti-incretin signals to balance the effect of excess insulin. And a result of this is that you can get altered brain-gut signaling. So there's some kind of abnormality in the mucosa, and you get to regulatory signals and brain-gut signaling that are abnormal. So if that's the theory, can we actually detect these, or are they just theories? And a lot of these have been hand-waving until recently, really until we started treating the area and then discovering after the fact what happened. And that's what happened here. So if we look at patients or even mouse models that are given a high-fat, high carbohydrate diet, we do see that there's an effect in the gut structure and function, and then we do see a downstream effect in the metabolic indices. And what are those effects, or what are those changes? Well, we see increased small intestinal cell mass, elongation of the villi, decreased crypt density, and an increase in enteroendocrine cells, which then leads to excess hormone secretion. So in other words, you have these cells that are producing hormones or other incretins, including GLP-1, but also potentially anti-incretin hormones. And so because of the increased cell mass, you may be having an abnormal increase in kind of counterproductive hormone signaling. So that's one aspect of it. And one group has kind of really taken on this theory. Another interesting study, a second way of looking at it, was to take biopsies in patients who had diabetes or did not have diabetes, and then using an AI model to compare the pathology samples. And what this group out of Mayo Clinic found was that in patients with diabetes, they found significantly increased numbers of inflammatory cells, particularly in the lamina propria and submucosa, and they seem to be clustered around the enteric nervous system in particular. So in other words, in patients with diabetes and metabolic syndrome, there's a significant amount of inflammation, and potentially the inflammation is clustered around the nerves. And this can kind of explain why there is altered brain-gut signal. Because remember that the enteroendocrine system really also includes not just the hormones, but the enteric nervous system, which communicates with the brain, which then communicates with the pancreas and other metabolic organs via vagal efferents and afferents. So maybe inflammation of the nerves is the missing neuronal link. So taking these two observations among the various theories, we could put it all together and say, okay, we have excess nutrient exposure and uptake, particularly in an unhealthy kind of Western diet. This leads to increased small intestinal cell mass and inflammation. This then leads to altered hormone secretion because of potentially extra cells that should not be there, and also gut-brain dysregulation via both the hormonal and the neuronal pathways. And we know from the bariatric surgeons, all the great work that you've done, bypassing this segment leads to multiple benefits. And so therefore, it must be the target that contributes to metabolic disease. And maybe we can do something about it and restore the normal mucosa. And maybe we can restore normal metabolic parameters. And so that's how we put it all together. So how do we restore normal tissue? Well, a nice property of the GI tract is that when you get rid of tissue, whether you burn it, you freeze it, you cut it out, the natural response of the GI tract is that it grows back into healthy tissue. And so these are images from the esophagus in patients that have Barrett's esophagus. You can see on the blue light image on the left, kind of this darker color, that's Barrett's esophagus. And for patients that have low-grade or high-grade dysplasia or even early cancer, we could do radiofrequency ablation using heat to ablate it. And then once it heals up, it essentially looks like nothing ever happened. And so it recellularizes in a healthy way. So based on these properties and this theory, there are multiple modalities really under investigation. And I say so far because I'm aware, now that we've shown that there is an effect here, the floodgates are starting to open, and you've got a lot of different players trying to get into this field. The first, duodenal mucosal resurfacing. I did put the company names here because a lot of right now in the early stages, it is kind of the names are used kind of interchangeably, but the company's named Fractal. They call it the Revita DMR procedure, or duodenal mucosal resurfacing. There's duodenal recellularization with electroporation, called the RESET procedure from Endogenics, and then radiofrequency RF vapor ablation from Aqua Medical. We're going to look at these three. And I think, you wouldn't be surprised to see just standard radiofrequency ablation being attempted soon. You might see cold or nitrogen therapy via spray or balloon. There's various modalities that may be used, and there may be others still on the horizon that someone here may think of as well. So the first one, this is the duodenal mucosal resurfacing, or DMR procedure, and it's done with endoscopy and also fluoroscopy. And the steps of the procedure are as follows. First, we take a look around and make sure that there's no contraindications. So make sure there's no polyps or ulcers or strictures or anything like that. A guide wire is passed deeply into the jejunum, and then the scope is pulled out, and this catheter, the Revita catheter, is advanced over the guide wire. There's several steps to doing one ablation cycle, but the first thing is that a submucosal injection is performed into, again, the third layer of the submucosa in order to protect the outer wall, because we don't want to hit the muscularis propria or the serosa. We just want to treat the inner lining, the mucosa and the submucosa particularly. And there's a set of needles that will do that kind of automatically. The balloon, while it's inflated, is then filled quickly with hot water. It's about 90 degrees Celsius. So I kind of explained to patients, if you ever drank coffee that came out of Starbucks or the brewer a little too early and you burn your tongue, or something straight out of the microwave, it's kind of like that temperature. And we march our way down with this catheter with cycles of injection in the submucosa and then heat, and then they cool it down with cold water. So they call this hydrothermal ablation, pumping water in, giving a nice little blanch to this entire segment. And we work from the distal second portion over to the ligament of Treitz. The reason we start at the distal second portion, we do not want to ablate the ampulla to prevent complications like pancreatitis and stricture of the pancreas and bile duct. And essentially we march along, and then this is a real video from one of the first cases that I've done, and you can kind of see this blanching effect on the tissue there. At a high level summary of the data so far, 0.8 to 1.2% decrease in hemoglobin A1C out to 24 months. And I'll show you in a second that just recently data was presented that the effect appears to be durable out to 48 months. And it's been shown to have improvements in insulin sensitivity and beta cell function, which is kind of, when you think about it a little bit fascinating and strange that you're working on the duodenum, but you're seeing pancreas effects, positive pancreas effects. And so this again goes to this idea that the duodenum is not an isolated organ. It's really the ringleader for all of metabolism. And we've seen reduced insulin usage and improvement in liver fibrosis and steatosis. And Dr. Galvao Neto, we're in the presence of greatness because as he pointed out to me in the pre-call here, he was the first to perform this procedure in humans. And I think this animation, if I'm correct, was also based on your inputs, or maybe even be your animation. So thank you for providing that I've borrowed outright. Some of the key trials to be familiar with, I won't go through this in so much detail because these are all still quite small, but essentially this is shown in open label studies and also in double blind studies to have an effect. So again, that's 0.9 up to 1.2% if we're looking at percent hemoglobin A1C, with improvements in insulin resistance and beta cell function parameters, and also improvements in liver fat. So the Revita 1 and 2 procedure, the Revitalize 1 study is currently on enrollment pause, and I'll explain why, but that is a US pivotal trial to look at patients that are on insulin and still uncontrolled for the diabetes. So we've started enrolling, and there's currently a pause because the focus has, just from practical reasons, has shifted to another topic that's hot and great right now. The second therapy, electroporation. So what electroporation is using electricity rather than heat. And instead of ablating the mucosa, applying an electrical current to the mucosa will essentially open up the pores of the cells. And so the pores are open, extracellular cations, particularly potassium, can then flood into the cells, and that induces apoptosis of the tissue. So instead of burning or freezing or cutting out the tissue and ablating it that way, what this is doing is using electroporation, or opening up the pores, to induce apoptosis and cell death in a kind of a more natural fashion. So you're kind of activating that process. And as a result, the theory is that this may be safer because you don't have the kind of the potential risks of ablation, which may be kind of deeper injury, delayed perforation, or stenosis or stricture. And the procedure in this animation, pretty similar. There's this device that's taken down. It's over a guide wire under fluoro, again, with this current generation device. And a paddle opens up, and this paddle has a circuit on the outside. Suction's applied to bring the mucosa towards the paddle, and then an electrical current is applied. And they've done dose testing to figure out, how much it seems to be safe and effective. And then the electroporation takes effect. You can actually see an immediate effect as actually mucus and what we believe may be kind of intracellular fat, so fatty duodenum, immediately gets extruded from the tissue. And then over the next few days, as the cells apoptose or die off, they'll slough away, and normal healthy tissue has been observed to grow back. And same thing, we're treating from the second portion to the ligament of Treitz with the current generation. Open label studies, pretty good effect. Again, 0.9 to 1.6% hemoglobin A1C improvement, and it's improving with dose optimization. And this is, again, what it kind of looks like immediately afterwards. This is an older generation catheter, but you could see some immediate effect. But this is not an injury as much as it is extrusion of kind of intracellular contents. The studies that have been published or presented so far, the REGENT studies were the pilot open label studies, and they kind of showed proof of concept. And we're currently enrolling for the RESET clinical trial, which is looking at patients that are non-insulin dependent type 2 diabetics that are uncontrolled. So A1C between 7.5 to 10.5. And I'll tell you that in addition to this published data, unpublished data looks like that the 2% hemoglobin A1C threshold may not be so far away. And so looking at these numbers already, these are already as good or potentially better than entire classes of anti-diabetes medications and are approaching some of the numbers that we can achieve with bariatric surgery. So quite intriguing. And so far safety, I'll point out that this region study, I mentioned earlier that 24-week outcomes were good. Just recently, within the last couple of weeks, the 48-week outcomes in that cohort of 41 patients was reported. And it seems to still be durable, it has durability, and notably 0 adverse events. And these procedures take about an hour or less to perform. So we're seeing pretty high numbers, almost as good as some of these medication agents with very, very safe safety profile, I should say. The third therapy, RF vapor ablation. So far, there's been at least 60-something patients, probably more at this point, treated worldwide, but a pilot study of the first 27 has been published, and they saw 1.2 and 0.8% improvement in hemoglobin A1C at 12 and 24 weeks, respectively. And what this is a little bit different. So you can notice here that this is a catheter that's going through the scope rather than over the scope. There's no guide wire, no fluoroscopies needed. And essentially what it is, it's somewhat of a nitinol basket. So there's kind of an umbrella on one end, an umbrella on the other end. And then saline is squirted through the catheter, and the tip of the catheter in this blue area has a little RF or radiofrequency probe, and that heats up and vaporizes the saline. And because you've got those two umbrellas that are opening up, you created a fixed chamber, and the vapor will then exert thermal injury or ablation of the mucosa and then immediately condense. So as you're doing this, you see saline kind of pooling after the steam kind of cools down, and they did work to figure out what's the right dose. The key advantages of this are that A, it does not need fluoroscopy, B, it does not need guide wire, C, it's through the scope. And so immediately these should make it a lot easier and more accessible. And then D, you're not, because it's not a kind of a larger beside the scope device, this therapy can actually be exerted beyond the ligament or trites. So really, as far as you can push the scope down with a push enteroscopy is as far as you could treat. And so I'm, talking to the investigator and the fellow in London who did the initial studies there, they're getting 50 or 60 centimeters past the ligament of trites with their current technique. So this is not just treating the duodenum, but also treating the proximal jejunum, which I think is believed to be just as important as the immediate foregut. They are now planning their clinical trials at the first 5 sites in the US, followed by a pivotal, which I'm certainly hoping to be a part of as well. And so this is what it looks like, kind of a cage that's created by 2 umbrellas, and you do the ablation, and then you can recapture, push forward, and continue marching along. So all of those studies right now, we're looking at type 2 diabetes. So that's been the first target. And we could talk about in the Q&A why type 2 diabetes may be the better target initially from a regulatory and a reimbursement standpoint. But some interesting things kind of came up from those initial studies. So let's turn our attention now to obesity. And GLP-1 receptor agonists, all the rage right now. But they're not perfect. Why? I think this is no news to anyone, but they're expensive and costly. There's side effects. And because of these side effects, there's very high discontinuation rates, double digits, mid double digits in many patients. And then the other problem, even if you can get it and you could tolerate the side effects and you can continue to get it and there's no stock issues and things like that, the other problem is that you might need to be on it forever, because if you stop it, there's substantial weight rebound with discordant fat and muscle regain. So while you may lose both fat and muscle, patients that stop the medication may actually regain fat without regaining the muscle, and the weight comes on pretty quickly within the first few months of stopping the medication. So these therapies, while very good in general and a population level, for an individual, it might be a big swing to start a medication that may be lifelong. If I have a patient who's in her 20s that comes in and says, hey, I want to start one of these medications, we can do it. It may be better than doing nothing, but just realize that may be a big swing to put someone on what right now is an injectable agent that may be lifelong with side effects. And so these are not perfect medications. Well, are there any strategies that we can do to address that problem? The problem of weight regain and the problem of having to be on together. And in duodenal mucosal resurfacing, there were some initial hints of a potential benefit. So in a pooled analysis of 128 patients who had an average baseline of obesity, so BMI of 31. They looked at 89 patients who went DMR versus 39 who went sham. And they had a short recovery diet right after the procedure, but no other kind of high intensity diet and lifestyle measures. And what they did notice is there was a little bit of weight loss in the patients that had DMR. So 2.9% versus 1.5% in the sham patients. Not huge. I don't think that anyone's arguing that this is going to replace something like bariatric surgery or take on the GLP-1s. But there was a little bit of hint, okay, maybe there's something there. There was a single arm study in Amsterdam in patients in the Inspire study that had DMR and also GLP-1 liraglutide. And they did show some weight loss. So again, not really huge weight loss. These were both really diabetes-focused studies. But interestingly, they noticed that patients who were able to stop the liraglutide for their diabetes after 1 year did not regain weight. If they had the DMR compared to patients who didn't have it at all, would continue it. So they kind of had small signals, and some of it is unpublished data that they kind of saw that, hey, there might be something here with the patients that stopped the GLP-1, and these GLP-1s were mostly for diabetes, not for weight. But based on this, it was important enough of a signal, and they saw it important enough on unmet need that they paused enrollment in the diabetes study and turned their attention entirely to weight maintenance. So that's why they call it the REMAIN-1 study. The enrollment is actually essentially complete. This has been potentially the fastest enrolling GI study ever that anyone can think of, and you're going to see why. So the question of the study is really, can DMR be used to maintain weight loss after someone's taken a GLP-1 receptor agonist and stops it? So we stop the GLP-1 receptor agonist. So the study starts with, we take patients that have obesity, they do not have diabetes, so this is non-diabetics, and we give them free tirzepatide, and we work very hard with the diet and lifestyle program and monthly visits until they achieve 15% total body weight loss. So that alone has proved to be very popular because these are medications that are very hard to get, certainly here in Southern California, between insurance and pharmacy stock and everything like that. And so the patients are all given tirzepatide, and we're working very hard to get them 15% total body weight loss, which should take hopefully just a few months. Once they achieve the 15%, we then stop the tirzepatide, and then a week later, they come in with me to do a procedure. And during the endoscopy, we then randomize them to have a DMR versus a sham, in which we move the catheter through, but we do not turn on the hydrothermal ablation or the hot water. So we don't do the burn. And then the key endpoint is afterwards, we watch them for a year and we see what happens to their weight. And the question is, do they maintain their weight loss after we stop the tirzepatide and then do the procedure? And we're following them out to a year. And so, so far, again, the enrollment target has already been met. Just in less than 6 months, we're already at 500 patients nationwide. A total of 360, I believe, are going to be expected to make it, for one reason or the other. And then we're going to watch them, and we're going to see, can this be used essentially as an off-ramp on patients that are on GLP-1 receptor agonist medications? Hot off the press, literally within the last, I think, 48 hours, the open label cohort called the REVEAL-1 cohort was published. And so this is the data. So this is, there were 22 patients that have already had the procedure. 13 of them have been followed out to 3 months. These were patients who were already on some kind of GLP-1 therapy, and they range from just being on it for 5 months to 3 years. So they don't have to be, it doesn't even have to be tirzepatide, but these were just patients that were already on it and were interested in stopping it. And they had all achieved total body weight loss exceeding that 15%. The median was 20.9%. So patients were already responders. The GLP-1 agent was stopped. They underwent the DMR procedure. One patient did regain weight out of the 13, typical of what we see with tirzepatide withdrawal. So that was the SURMOUNT-4 study. And by 3 months, you usually see 5 to 6% total body weight gain back in patients who stopped their tirzepatide. So that's from the major kind of randomized controlled trial. However, 12 out of the 13 patients either lost or maintained their weight. So after 3 months, the total body weight change was only 0.46%, or roughly 1 pound. 6% or 6 patients out of the 12, 6 out of the 13 actually continued to lose weight afterwards. And they essentially saw that between the 1 month and 3 month, the weight gain remained stable. So there was no, once, if you held it at 1 month, you held it at 3 months. So at least this is quite encouraging that just from this small group of patients, that doing a DMR procedure after the GLP-1 has kind of exerted its effect may serve as a successful off-ramp. And so I'm excited. We have, I think, 20-something patients at UCLA that are in their tirzepatide run-in, and so I'm expecting to have them visit me in the endoscopy unit in a few months. So in conclusion, I hope I've explained to you today that metabolic syndrome can be detected in the proximal small intestine following decades of what you as the surgeons have already known, that this is clearly the target for metabolic disease. Ablation or recellularization, because electroporation is not really ablation, it's really a non-thermal therapy, may reverse the pathology to reestablish a healthy gut-brain neurohormonal signaling. And there may be benefits for type 2 diabetes, fatty liver, and maintenance of weight loss as an off-ramp for patients who are on GLP-1 receptor agonist medication. So this is, again, I think I'm excited. You know, you asked the question of, is this worth it? Is it worth following? I certainly think so. I think there's a lot of attention and a lot of excitement both in gastroenterology and bariatric metabolic surgery. And in fact, you know, I'm a proctor for the first two studies, and many of the endoscopists that I get to work with are surgeons. So there's actually the majority of the endoscopists are surgeons and not gastroenterologists. So it's really a pleasure to work with you and your colleagues, and I really think that this is going to be an exciting field that we can tackle together. So thanks again for having me, and happy to take questions now and in the panel.
Dear Adarsh, thank you very, very much for a wonderful talk. I always enjoy listening to your presentations. It's been very educational. I'm going to ask you a similar question to the question that I asked Manuel, or a little bit similar. So what do you think is a big advantage of this procedure? What is its most promising feature? I know you talked about it on your presentation, but if you had to highlight one, and then what is the biggest disadvantage for someone who wanted to adopt the technology? Is it access to it? Is it the financial aspects of implementing a program like this? Tell us about it.
Yeah, two really great and important questions. So the first one's easy. This is, I don't think I've ever had a patient that once they've heard about it and I just talk to them and do the informed consent that has said, I don't want this. Because look at the value proposition. This is an outpatient procedure. It's one time. It takes me about an hour to do, of which you know, a lot of it is really just anesthesia time and doing the endoscopy. So the actual treatment is about 45 minutes, especially once you get good at it. You have to do a restricted diet for about a week, but then after that, there's no real major diet or lifestyle changes. You know, this is somewhat independent of that. And at least for what we have from the European data for DMR, the durability is now beyond 1 year. It looks to be at least 2 years durability. And, you know, we don't know if we need to or we can retreat. They're going to be looking at that soon. But yeah, if it means that I do one procedure, an endoscopy, let's say every 3 to 5 years to maintain your diabetes remission, I don't know many people that would rather be on a daily or weekly medication or, you know, or which is really the standard of care right now. So the value proposition compared to medical therapy is tremendous. And so I think that, you know, it's an easy sell to patients. You don't have to sell it. It really sells itself. And then the adverse event rate is so low that, you know, it's going to be tough to kind of consider surgery, especially if we start to achieve the A1C numbers that someone, you know, may achieve after bariatric surgery. So I think, you know, we could talk about patients that have both obesity and diabetes. You know, maybe we combine it with the procedure that Brandon's about to talk about now, but you know, we're kind of exerting the effects of bariatric surgery stepwise using different techniques in various parts of the GI tract. So it's an easy value proposition for patients. Now, in terms of the getting it out to providers and to patients, I actually think right now it's still a technical and an engineering challenge because the procedures are somewhat tedious, to be completely frank and honest. And that's a lot of what I'm working with the companies on, is make it that not just an interventional gastroenterologist or a bariatric surgeon who has extra interest in this can do it, but you can hand it to any endoscopist and have them reproduce it in a safe and effective and durable manner. And so getting rid of things like fluoroscopy, getting rid of the guide wire, making the catheters devices easier to use, I think are all you know, engineering challenges that these vendors and others are working hard to tackle. From a reimbursement standpoint, these studies were designed with reimbursement in mind. So let's say you're an insurance company and I say, hey, I can use this procedure to get this % of your patients off of insulin or this % of your patients off of GLP-1 medications. That's an immediate value proposition for the payers, right? I could put a dollar number on that right away. And I would hope that they are more motivated to cover that because, bariatric surgery took decades to get payer coverage. And even now we fight all these battles to get it. And GLP-1 medications for obesity still are not covered by a majority of, for a majority of patients that could get it. So I'm hoping that the way that these studies are designed and the targets and the unmet needs that we're tackling will result in a much faster pathway to things like CPT codes, but also most importantly, to get out to everyone reimbursement, frankly.
Thank you, Leo, Adarsh. And I like how you specified that the name should be endoscopic or it should be duodenal mucosal recellularization. I hope I said that word well. It's a difficult one, but rather than resurfacing, it's recellularization. And if you think about what you mentioned, if you think about the marriage between anatomy and physiology, a perfect procedure, endoscopic procedure to marry the two of them, it's this one. And so that's why a lot of people are beginning to talk about endometabolics rather than just endobariatrics, it's endometabolics.
Yeah.
One last question for you before we go on to the next speaker. How difficult or how easy is it to teach residents or fellows or trainees?
I would say moderate. In the scheme of endoscopic procedures, this is it's not the easiest procedure to teach at the moment. The steps are very similar to the steps that we use when we're doing duodenal stenting. So if anyone has any training or familiarity with antral stenting for someone who has duodenal obstruction from a pancreas cancer eroding into the third portion or something like that, but with a catheter that's a little bit floppy or stiff depending on which direction compared to a duodenal stent. So it does take a significant kind of you have to be pretty facile with endoscopy, particularly endoscopy in the small bowel before you do it. So I would want to see someone that can do an endoscopy without having to think about it before I would consider teaching this to them.
Okay, wonderful. Thank you very much, dear Dr. Thaker. Dr. Thaker, once again, for everyone joining us, is an assistant clinical professor of medicine at UCLA. He is well known for his work in endometabolics and endobariatrics. He's a therapeutic advanced endoscopist and gastroenterologist, and always a pleasure to work with him and learn a lot from him. From a surgeon to a gastroenterology point of view, this is the perfect friendship and collegiality between GI docs and surgeons. So thank you very much, Adarsh. Congratulations.
Thank you.
Thank you. And now it's my pleasure to my co-moderator, Dr. Esquivel, is in the OR. She has a little emergency to take care of, but it's my pleasure to introduce the next speaker. And the next speaker is well known throughout the world, and this is Dr. Brandon VanderWel. I also had the pleasure of meeting him face-to-face in person at SAGES 2025 in Long Beach, California. But of course, he's well known. I already knew about his work. And later on, I saw him at the Endobariatrics course where I learned about ESG. So Brandon, Dr. VanderWel, received his MD degree from Loma Linda University in Southern California. He then completed residency in general surgery at Swedish Medical Center in Seattle. In residency, he developed a passion for metabolic and bariatric surgery and for bariatric endoscopy. So he went on to do fellowship training in MIS and bariatric surgery at Legacy Good Samaritan Hospital in Portland, Oregon. And then he decided to settle in the Seattle area. And so he joined a phenomenal private practice group, which is called Eviva, where he is tremendously productive. He does a lot of ESGs. He's done hundreds of these procedures. For those who don't know and are joining us, ESG stands for endoscopic sleeve gastroplasty. He will be extremely qualified to teach us about it. And on a personal note, he and his wife enjoy the Pacific Northwest, which is a beautiful area of the United States. And he enjoys doing outdoor activities, and of course that involves chasing his 2 young children who keep him very occupied. He enjoys biking, hiking, camping, and photography. And so with all of this, I leave the podium to you, dear Brandon. Thank you very much for joining us and welcome.
Thank you, Rodolfo. That was a very kind introduction. So, yeah, before as I'm teeing up some slides here, let's see here, PowerPoint. Yep, Zoom, allow. Sorry, guys. Had to reload later. Okay.
No problem. Take your time. And in the meantime, I remind everyone to please type in your questions at the Q&A box. And if you don't have any questions, but you just have comments or congratulations or gratitude messages, you can type them in the chat box and we can see your presentation, Brandon. You're good to go.
Excellent. Great. I want to give a special shout. Thank you, Rodolfo and Micaela, for setting this up. And then, you know, Manuel has been really the father, honestly, of all of us for his endobariatric stuff. I watched, when I started doing my ESGs, I watched a lot of his early videos, you know, a long time ago, you know. And yeah, I think, you know, we all stand on his shoulders and the work of his, you know, colleagues of his time. And really grateful for all the work that he's done. And Adarsh has a amazing procedure, you know, talk too, and fascinating topic. So thank you for the opportunity to talk about the endoscopic sleeve gastroplasty, the ESG. I'm Brandon VanderWel. I am a consultant for Boston Scientific. This is the practice where I work. So it's called Aviva. We're a private practice of bariatric surgery, one of the first in the world to do outpatient bariatric surgery back in 2007. The first laparoscopic sleeve in the Pacific Northwest, outpatient laparoscopic sleeve, outpatient gastric bypass, part of the initial FDA balloon trial, one of the first in the Pacific Northwest to do the ESG. So they were kind of like I joined this group as soon as I found out about their passion for bariatrics and for innovation, and which was really helpful for me to get going at that time in 2020. And for all of you residents and fellows, thankfully, I think it's going to be a lot easier to get into endobariatrics now, which is super exciting. So many good things ahead in our practices, and so many great things ahead for helping patients. So I always kind of like to begin with, you know, the problem, because a lot of people, you know, I don't think we have to make this argument as much anymore, but like, why do we even have endobariatrics? Why do we need this when bariatric surgery does work really well? And I think it's because, and I like to like ingrain this in us, because we need to keep this at our foundation of our psyche, which is we need to help more people. There are so many people out there that need help. This is the population of the United States, 330 million people. Here's the people that are normal weight or just overweight. Obese is 108 million people. Severe obesity, 30 million extra people than that. That combination is 140 million people. That's the population of Russia. That is the amount of people that have struggled with obesity in this country. And we have some, you know, some treatments for obesity. And those are, you know, eat less, exercise more, you know, psychotherapy, hypnosis, medical weight loss stuff now, endobariatrics things like intragastric balloon. And now, you know, we'll talk about the ESG. But of course, there's laparoscopic bariatric surgery, which is the gold standard, hands down, no questions asked. It is the best treatment. And this is how many people use that therapy. It is, boom, right there. A fraction of the amount of people that should be using this therapy do. And, you know, we got to really ask ourselves, why? Why are so, I mean, if you missed it, look at that. It's why are so few people getting the gold standard therapy for a treatment for a disease that is almost half the population? So it's a complicated question, complicated answer, but I kind of break it into a couple things. And one is denial. Some people don't feel like they're struggling with, oh, I can fix it, you know, whatever. If I just got to put my mind to it and I'll get out of here. A big piece of it's fear, though. I think a lot of people have a misconception of what bariatric surgery is, and a major fear of just, you know, number one, saying, going to see a surgeon, going under anesthesia, but especially saying, I'm going to have incisions, I'm going to have a part of my body removed or some plumbing moved around because I struggle with my weight and I just feel like I can't get my act together. And then there's the cost aspect is another piece too. And really what this comes down to is we need more tools to treat obesity. We really do, which is why endobariatrics, and this is a fantastic slide. Manuel talked earlier about the intragastric balloon. We talked about the DMR procedure, which is super cool. That was a fascinating topic. And I think it's going to help us, if it can answer one of those questions of like, how do we get the successful people successfully off of a GLP-1? Amazing. But the endoscopic sleeve gastroplasty, the suturing procedures here in the middle. Can you guys see the mouse? Is that mouse visible? I'm not sure if I'm wasting my time with wiggling this mouse.
We can see the mouse moving.
All right, cool. So this is the suturing procedures where we're remodeling the stomach. That's what we're going to talk about today, mostly focusing on the endoscopic sleeve gastroplasty with the overstitch, because that's the one that's most commonly done. As the, you know, when you're a resident or fellow, like looking at bariatrics and things like that, I think it's really important for us to have a framework of what these tools are. because these are really that. They are tools. They're not cures. They are not magic wands. They're not silver bullets, but all of them have their strengths and weaknesses. So the more we understand these tools and how they act and which pieces we can maybe start putting them together better to do a better and better job of treating this very complicated, very tricky disease to treat, which is obesity. First thing I like to look at is success. So what is our end goal here? I think all of us came into medicine because we really wanted to help people live healthy, full, and wonderful lives as free of disease as we can possibly make them. And that is the goal with our patients when they come to us because they're struggling with obesity. They want to be on the road of health, which is this winding path throughout their life. And they want to drive on that road with a healthy body, which is their car. They want their car to be working well, just a delight to drive and just enjoying the drive, enjoying the view, and really seeing, just living a full life with a healthy body and a nice experience. That's what they're going for. But most people that struggle with obesity, this is what their reality is like. They're out of control. They just don't feel like they can drive this car when they're trying as hard as they can, but this thing feels like it's breaking down all the time. It's not responding. It never does what they want it to do. And it's just a disaster. This is what I love about bariatric surgery. Most of medicine, patients have a baseline. Something bad happens to them. It brings them below their baseline. They come to you because they want help to get back and fix this problem so they can get back to baseline. Unfortunately, patients that struggle with obesity, that huge section of the pie chart, their baseline, that sucks. They hate their baseline where it is. And the tools that we have can really bring them up to a baseline so they can live that awesome life and they can just live so much more full lives. And it is the best field. I think you just feel like you win the Super Bowl like every week in this field. So let's conceptualize this framework, break it down a little bit more. So I like to think of things in the sense of like, so when we're trying to drive this car, there's a lot of different facets to it and get on this journey. There's the hardware, there's the car itself. So there's the engine, there is the power steering, there is the brakes with the power brakes, there's the transmission. And people that struggle with obesity feel like all these things are just not working. The engine's not reliable, the throttle's all jerky, the brakes don't really work, the steering wheel's really sloppy. And it's not working for them right now. And no matter how hard they're trying to drive that car, they just does not want to work with them. And then there's the software. So the software helps all of the mechanical parts work more smoothly, but it also gives you some lane assist, gives you some adaptive cruise control, maybe some automatic braking if you're about to get into a crash. And then there's also guardrails. And so this is the guardrails. This is specifically in obesity. I like to think of it in the sense of the size of your stomach, the amount of food that you can eat. And what happens in our tools that we try to offer people is we want to give them a guardrail around the most dangerous curves, which is generally overeating and eating poor quality food. And there are different tools that have different strengths and weaknesses on the guardrail aspect. And we need to make sure that we understand what those are, how to live within them, and how to utilize them and protect them. And a big important part of this journey too is the operator. If you're driving a car and you want to get from point A to point B, you need to know how to drive. You need to know where you're going. You need to be paying attention. And those are things that I think that personally, I, as a bariatric surgeon, love and embrace, is that we get to help patients get better than not more than just tuning them up like a mechanic or a plumber. We get to help them, empower them, and give them a couple of little aspects and nuggets and help them really coach them up in improving so many other aspects of their life, which is amazing. And I think this is one of the best parts of my favorite part of the job, is that it's not just that the numbers on the scale are better and they can go buy clothes off the rack and their diabetes is gone, their hypertension. It's that the story that they tell about themselves and the empowerment that they feel to now be able to live a great life is incredible. So this is the part where I tell people, like, these tools do not give you a perfect luxury car with a chauffeur that's just going to drive you through this. That's not the way this works. What we're doing is we're tuning up the cars, and that has different aspects of the tuning up part. And we need to work with all these things to get you down the road as well as we can. Of course, as with anything, there are risks and there's a maintenance that's required with any tools. So when you adapt to a tool, there are certain risks that you take on, and there is a certain amount of maintenance that a tool has. So like certain cars are more high maintenance than others. They come with more, I kind of think of it as drama. Your Ferrari has a lot more drama than your Camry, and it takes a lot more high maintenance. And so there's these tools, and we need to think about that when patients are thinking about this as well, and be able to tell patients what these are and really find the sweet spot for whatever that patient's going to look for. So I'm just going to blast through some of these real fast because I think it's helpful to give us that framework. So diet and activity. So what it is, we're just telling people, like, get your act together, level up your operator aspect. You're not changing, not really very risky. It's not really any maintenance technically, but it's very hard to do. There's no hardware upgrade. You're not helping them with that at all. The software upgrade, actually software being like your chemistry and your hormone levels. When you stop going into a calorie deficit, just by diet and activity, everything gets harder. You get super hungry. You just can't stop thinking about food. It makes it very challenging. There's no guardrails in place. You have a big stomach. That stomach wants to find food and eat food. It's very challenging. So overall, it gets a sad face. The GLP-1s, that's the new kid on the block with bariatric surgery, but really this is the GLP-1s world and we're all just living in it. But interestingly, when we look at it, what does this tool actually do? And that is, it gives us a software upgrade as far as the chemistry and the hormonal level. It sort of gives a guardrail, a little bit strengthens up our guardrails because it makes people feel full a little bit more. But anyone who's treated patients with GLP-1s for any amount of time knows that that guardrail is so much easier to blow through than any of the other procedures that we'll get to. And then the operator, it kind of upgrades the operator because I do think it does have a dopaminergic decreasing of vices that we see, which is fascinating. But and that's a great thing that we could potentially, add on to things as well. But it does make it, it has some great aspects. There's reasons why this works. Its risk is low. Its maintenance is generally, it is maintenance. It does require some maintenance because when you stop these medications, what we see is, like, we can see some good progress, but the maintenance of that it's challenging. In the clinical studies, where the best weight loss is seen, even after patients stop it, they have a really challenging time maintaining that weight loss. In real world studies, like in this study with like a big, tens of thousands of patient database of real world of data points, shows that our weight loss, number one, for semaglutide, all comers, is like 8-9%, and it's 14% with tirzepatide. And it's very challenging to maintain long-term. But I think this is a really cool tool. I think it's important to understand where the strengths and the weaknesses of this tool are, to maybe be able to use them all in different ways together. Dr. Manuel talked about the intragastric balloon, which is a great, and people just understand the nice thing about the intragastric balloon is that people aren't really under a delusion that this isn't temporary. It is, by its very nature, has a finite time period. And then it's like, hey, I know I'm going to be on my own to an extent, or I have a plan afterwards. And that's what brings us to the endoscopic sleeve, gastroplasty. So what I see this as is an upgrade to the hardware, in that what it does is your stomach is this big bag, and you have that overstitch, and it comes down through your mouth, and you take full thickness bites of that, and you crumple down the stomach. And we'll see how we do that in a second here. But what it does is it makes the stomach smaller so that, number one, your stomach isn't as big, so it can't fit as much food. That's the guardrail portion, keeps your portion sizes there. But also, we did see, like in Dr. Thaker's talk, that mucosal layer does have a hormonally active aspect when it's in interaction with food. And when we decrease the surface area of that interaction, we do really seem to see an improvement in people's satiety and decrease in their appetite. And it really is very helpful on a software level, like on a chemical and a hormonal aspect. And we see that when we've studied it, GLP-1 levels, PYY, those things have actually improved in ways not quite as significant as bariatric surgery, but we do see some helpful improvements. The operator, it's very helpful to have a smaller stomach. And what people will say afterwards is like, it's just, I have tried to do healthy diets before. I've tried to eat healthy food in small portions, but I've always just struggled. And now I can just do it. Instead of fighting my body, I'm working with my body, which is really, really cool. This is a sleeve specimen I took from a laparoscopic sleeve one day when I was doing sleeves and an endoscopic sleeve. And you can see here, what it does is that it takes those full thickness bites, and what you do is you make that in an orientation around the stomach, and then you cinch it down, and you make that smaller shape. You can see here, So that's permanent suture, getting full thickness bite, and really getting approximating the tissue, the serosa to serosa on the outside. And when you give a good secure closure like that, like that's a surgical technique. And I think all of us see that that's the way we would do like our fundoplications in anti-reflux surgery. That's the way you do like application if you were doing application over a band. And if you do a good job of that, that has a very good chance of being a good intervention now and being durable. The really nice thing about the endoscopic sleeve ESG is that its risks are very low. And we'll see that in a second here. And its maintenance, the drama level, I feel, is the lowest of all the procedures that I have ever done. It's lower than the laparoscopic. Like the amount of issues that people have, they don't really get worsening heartburn. They don't really get worsening abdominal pain. That's very rare. Like you just, when you ask somebody like 6 months, a year, 2 years, 3 years, 5 years afterwards, the drama level, the issues that people have with these are very low. So it's a very cool procedure. How does that compare to like the bariatric surgeries? You know, the bariatric surgeries have more of a hardware upgrade. Like it is more intervention on the hardware part, but that's also probably why we only see a sliver of people showing up for it. They're really concerned. They're really apprehensive about that massive jump to the hardware upgrade. With that hardware upgrade, hardware always trumps software. And that software upgrade is significant, the most significant intervention we see of all the things, hardware and software. Really strong guardrails, really helpful for all the operator stuff. But you know, that comes with certain things. And I think it's important to realize that all of these things have their place. But the reason that, you know, our adoption of bariatric surgery is so low is that people are worried about a lot of the maintenance issues that come with bariatric surgery, some of the drama that comes with it, particularly with the malabsorptive procedures, but also, you know, they're worried about such a dramatic intervention. So let's talk about the endoscopic sleeve gastroplasty. Brief history. First initial publication was in 2013, showing safe in humans. We have 5-year data. This was out even when I just started doing ESGs in 2020 from Dr. Reem Shariah, showing durability of the weight loss around 15%. The notable study is the randomized controlled trial, the MERIT trial, that showed the ESG is a great tool for class 1 obesity with 50% excess weight loss essentially and about 13-14% total body weight loss, certainly better than control with a crossover design with very low adverse effects. Another great study that was done is 3,000 patient 3-year data showing that endoscopic sleeves versus laparoscopic sleeves was 14% total body weight loss versus 19% total body weight loss at 3 years, and which is, you know, the difference there was, you know, certainly in favor of the laparoscopic sleeve, but that's a good, you know, that's a good, still a really good intervention. Safety wise was very safe, very low complication rate, and a very good improvement in comorbidities of hypertension, diabetes, and dyslipidemia. More recently, ESG data. This is class 3 data. So people with class 3 obesity showing, you know, 20% total body weight loss on average, excess weight of 50%, and with low complication rates and a very good intervention. This led to the IFSO statement in 2024 that said that for class 1 and class 2, endoscopic sleeve gastroplasty is a very legitimate and very positive intervention. And for class 3 people, they should certainly, of course, really think about metabolic surgery and bariatric surgery. But the endoscopic sleeve gastroplasty is still a good intervention for those patients. A meta-analysis of that time as well showed around 50% excess weight loss and around a little bit more than 15, 16, 18% total body weight loss for most studies seen, with that being maintained from 2 years, 3 years, 5 years. So where are we at with the endoscopic sleeve gastroplasty from a data standpoint in 2025? We kind of discussed that part, but where are we going? So there's some advanced techniques coming down the line. There's the endoscopic sleeve with third space in the third space as well to improve efficacy, which is pretty wild and pretty exciting to do. It's hard to scale though, because you have to have a significant amount of advanced skills. There's the ESG plus gastric mucosal fundal ablation, which has shown some very positive total body weight loss of 23 to 24%. The ESG and GLP-1s, how do those things go together? ESG versus GLP-1. So if you do a head-to-head comparison from both an effectiveness standpoint and from a cost effectiveness cost standpoint outright, the endoscopic sleeve beats the endoscopic sleeve beats semaglutide in both 5-year weight loss and cost effectiveness by almost $30,000 here in the United States. But really, this is what I truly believe. That's why I started with that whole pedantic framework of things, is that I really believe that we are in the and era. Procedures and, maybe even other procedures like the DMR, like Adarsh was talking about, procedures and maybe a GLP-1 for a time, like an adjuvant therapy like we do in cancer. And this is some data that was presented that shows that oral semaglutide plus ESG with at 6 months with 20% total body weight loss versus 15% with ESG alone. This is a study with some very reputable authors in it as well, with ESG with semaglutide showing, at 25% total body weight loss at 12 months, which is very exciting. And you can see in the box and whisker plots here that the ESG is really, it does well. Like that's 18% total body weight loss at 12 months. That's very solid. All the, expensive GLP-1s would love to have that data in real life. And then we're also seeing on top of that, plus a little bit of GLP-1 is just looking like a great combination together. So, all right, let's talk a little bit about technique. So, how do we do an ESG? I'll kind of share a little bit of my experience here. So I use the Apollo overstitch. I don't have as much experience with the other devices, and generally there's not as much of that done in the United States, and it's less rare to see them in general. But the full thickness bites is critical. You have to get full thickness bites. If you don't get that, there's no other point of doing this. Then you want to be able to, once you get a full thickness bites, you need to set up those bites so that you can actually cinch that tissue together and really approximate it. Because if you don't, you do risk having sort of a ceton or a cheese wire sort of physiology, where you could put too much stress on strangulate tissue that's right against one of that permanent suture, and it'll erode through the stomach. I usually use about 7 to 10 sutures in a U, I, or a Z pattern. That pattern is done usually with 3 to 9 bites. So here's the pattern for my U stitches here. It's like I go, from distal to proximal, 1, 2, 3, 4, 5, 6, 7. This is an example of a 7-bite one. If in lines, you can go 1, 2, 3, or 1, 2, 3, 4, 5. And then I also do posterior to anterior as well. So just from the same way that you go posterior to anterior on the upper part of the U, in the line part, you can go posterior to anterior as well. I do like to line up my entrances and my exit points to all sort of try to be in a line. And you'll see that. I'll show the video that I showed from before again too. Maybe you can appreciate that. You try to really get that suture in a line so that when it cinches together, it makes it rolls everything in nice together really, really well. I do sometimes use a Z pattern. There's a lot of different patterns out there. All of them have been shown to be should generally be effective. So it's kind of whatever your familiarity is, but I like these are the patterns I like that make sense to me, and it really helps me, I feel like, do the best job. So a Z pattern, I usually actually go from proximal to distal on this one. And I use this just when I have very large stomachs that are very wide. And you have to do a lot of sculpting of this stomach because you're not removing anything. So you're trying to figure out how you're going to manage the volume of that stomach while you're taking those bites. What's the spacing between the bites? That's always a tricky question. I generally like to think that the anterior to posterior difference between a bite, I use the NXT on a single channel scope, and that does give a little bit larger bites. It's close to almost 2 centimeters sometimes if you use the full tower size of those bites. And I usually like to think of, having the spacing anterior to posterior wise being a 1.5 to 3 centimeters between the exit of one suture and the entrance of the next suture. You space those out from an anterior to posterior direction. Your proximal to distal spacing, I usually like to think of that in about 1 centimeter to 2 centimeters max, depending on where that kind of falls in the different folds and the columns of the tissue. I got a fancy AI generated graphic here of a side view of a stomach wall. So this is looking at it from the side. So this is the stomach wall here. And think of it like you grab the bite and you take it and you're taking bites through here. And each of these bites with the suture, this blue line here, going through there. How many bites do you take? It's hard to know exactly what that is. You want to weigh there's a couple things you're weighing when you're taking these bites. The more bites that you take, the more stomach you're securing down, which I think is a good thing. The downside, the trade-off of that is that each of those bites gives thickness to your suture. And so if you only have 2 or 3 bites, you have nice big looping, pockets, and you really condense the volume of the stomach with minimal thickness of your suture, which is a positive, but you do have these pockets back in there. If there's any sort of failure in any of those portions, then, a lot of that can open up. But if you have a very thick, lots of bites that you take in there, if you even have just like a 25% atrophy of the tissue thickness in there, which you're going to have some atrophy as it's becoming more inert, then that will loosen up. That opens up about 25% space on each of single one of those bites, which could add up to be significant. So I've kind of demonstrated here. I just took the same line and I decreased the thickness of that line by 25%. And you can see how that does change how maybe secure your suture is going to be. This is the interesting thing and the complicated thing about doing endoscopic sleeve gastroplasties is that there is a lot of nuance, and there's honestly quite a few questions that we don't exactly know, which I enjoy the art part of it, of really creating these things and bringing them together. How do you determine what the spacing between from when you have a suture, let's say a U, you go down the line and then you're coming back up on the line on the next part. So I conceptually think of that as we're going to take a top view now. So this is now looking down at the stomach, say. This is the sutures that we did before. So this is a suture, and this is, this previous bite would be like, this is the top of that. And this is a different, suture 1, suture 2, suture 3. And what this is sort of that line that I kind of describe it as a wall of suture that's kind of bringing everything in more narrow towards you. And what I like to do is conceptualize this as the floor, and this is the wall. And I like to put my helix, which grabs your tissue to get a full thickness bite. I like to put it right about the junction of the wall and the floor. Putting the helix in there, and then you pull that out, and you get this tent. And that's where you're, number 1, you're getting a nice full thickness bite. Number 2, you should see this nice clean tent come towards you so that you don't get anything else outside of the stomach. And then there, you're going to want to take your bite right there, right in the middle of that thing, so that you get a nice, good, full thickness bite. That's not too much of a space away from here. I like to have my tent to have I kind of describe it as sort of a relationship here, like a plateau here, and then it falls off towards the floor in that direction. Those are my visual cues that I look for trying to conceptualize how I'm making sure that my spacing from a proximal to distal standpoint is staying on point. Then you advance, you move, bring your helix in, get your overstitch out, and take a bite. Nice there, nice big bite. So if you see this again, you can see here like the line, the full thickness bite. See how each of these lines tries to line up in a nice, fashion that it all goes from one to the next, so that when you suture it, it can really it all comes together really nice. So you can see this in incomplete cinching right here, and you want to do that last final bit, boom, yes. So doing these procedures well is very rewarding, and it can help patients in great ways too. Also, adding the endoscopic sleeve gastroplasty when we've added it to our practice has really opened up a lot more of that bariatric surgery pie to our entire bariatric surgery practice. In the first couple of years that I did my ESGs, I did almost 470 consults for people that said, I saw the ESG on your website. I'm really interested in that. That really appeals to me. And that's why I reached out to you. We told the patients when they came here, it's awesome. We're only doing it because we believe in the ESG, but here's all the other options when it comes to bariatric surgery. Here's the laparoscopic sleeve. Here's what it is. Here's what it isn't. Here's what the gastric bypass is. Here's what it is. Here's what it isn't. If you're willing to undergo a laparoscopic sleeve, you should seriously consider it, because it is a really good tool, and it does those surgeries. They're really safe and they're very effective. But if that's not you, and the reason that I got doing endoscopic sleeves is because I know people in my own life that really need help, and they know what I do, and they know that that's never going to be them. But you can tell that the wheels turn when it comes to the endoscopic sleeve. And if that's that patient, I tell them, if that's you and you know you're never going to cross that line in the sand to join the surgery camp, do the endoscopic sleeve, hands down, no questions asked. It's the next best thing. So of that, 177 patients ended up doing an endoscopic sleeve, but also 107 patients that were were only interested in the ESG at first ended up being like, oh, bariatric surgery isn't as scary as I thought it was. Actually, I actually kind of want to sign up for that. And these extra people were never going to reach out to my office, because they were like, totally had a misconception of what bariatric surgery was. And I didn't think that was for me, but actually, I think I'm signing up for that one. Our total body weight loss for this cohort was 23%. Excess weight loss was 73%, with 2 adverse events. So one being like a stricture, with like a cramp that it was like essentially a muscle cramp that was just balloon dilated and fixed, and she did fantastic. Another one was a blood clot, a DVT. The significant remission and improvement in hypertension and diabetes. And it's been a fantastic addition to our practice. Recently, we've been going through some of our longer term data. And so we're looking at GLP-1s versus ESG versus LSG in our practice. So this is our preliminary data. It's not, we got a little bit more things we want to do with this stuff, but I think it's really cool to see that our ESG 1 year data around a little bit, like our average is a little bit higher 20%, 30% for our laparoscopic sleeve data. It's about maintained now with the 2 year ESG and LSG, 3 year as well. It's still in about that same category. How does this compare to GLP-1s, which everyone thinks, I mean, I'm sure you've all seen it, right? What people think GLP-1s are out there, like they really think that it's the cure to obesity. I mean, I had a pharmacist the other day say like, well, it doesn't seem like we need bariatric surgery more because we've cured obesity with Ozempic. And it's just like, this is what we see in our practice, which is what a lot of real life data is, which is 8-9% semaglutide, 15% tirzepatide. And it gets harder. It gets tougher at year 2. Like it doesn't get better at year 2 generally, because a lot of people are dropping off. They're struggling. And I think this is a wild slide. When we looked at this and we're like, wow, the implications of this is that 75% of people that get ESGs are doing better than 75% of people that do medical weight loss in our practice. 75% at 2 years, even 75% versus 75%. And I think it's a fascinating look. And I tell people, like, this is what my data is too with my ESGs versus my laparoscopic sleeves, which is 75% of my laparoscopic sleeves are doing better than 75% of my ESGs. But the nice thing about the ESG is that it's very low drama. If you want to go to a laparoscopic sleeve later, we can talk about that. And that's a very real option for you. And that really, really resonates with a lot of patients. So the future of endobariatrics, I think it's very exciting. I think we've, a lot of great presentations already today. Specifically with the ESG, the RUC survey, which is going to give the RVU value to the upcoming CPT code, is all going to happen within almost the next 6 months. Where we're going to be right now in a year's time when discussing the endoscopic sleeve gastroplasty is going to be interesting. Very, very potentially very exciting to have insurance reimbursement pathway looking forward. There will still be lots of work to do. Just like in bariatric surgery, we have lots of codes and RVUs and whatever, but that still doesn't mean everyone has coverage. But it's going to make this way more accessible. And for those of you who are residents or fellows, your ability to adopt endobariatrics into your practice is going to open up so much more when this stuff goes into play, because right now in our practice, like we're mostly a self-pay, like cash pay model for endobariatrics, which is what most of endobariatrics has been. It's been very little, very small section of that has been insurance coverage in the United States. And so getting insurance coverage is going to make this so much more accessible so that you can do this in more mainstream, venues, as opposed to something fairly niche like mine, or, high level academic, like Manuel and like Adarsh are in as well. We're getting better and better at training this procedure. So, if you're interested in these things, like our ability to get people up to speed keeps getting better and better, which is exciting. And we're gonna keep getting better, because once we have the insurance reimbursement piece, honestly, the next big question to answer is making sure we have quality and making sure that people that are doing this are doing it well, because it's a challenging procedure to do well. And it is a very rewarding procedure to do well, but it takes work, and it takes training. We're getting better techniques. I think we're going to keep getting better techniques, and also better equipment, and better integration with adjuvant AOMs, like anti-obesity medications. We're going to add magnets. We're going to add DMR to it later. Like, there's just a lot of cool stuff I think we're going to be able to do with this stuff in the future, and it's a great tool. So, as a resident or a fellow, what can you do now? How can you potentially set yourself up where you are to adopt endobariatrics or endosurgery, endoluminal surgery into your practice right now? I get that question a lot, in a lot of the courses that I teach. One thing I really, really encourage you is that every time you have some chance to scope, do it, of course. But also, when you're doing an upper endoscopy, particularly, really try to utilize the only thing you're doing with your right hand is going in and out with the scope. All the rotation of the scope is coming from your body and from the roll of your wrist and the wheels on the scope together. Like, those things, because when you're doing endoluminal surgery, this hand is precious. You really need to be able to use this hand to do things on all different other places. You can't waste it on controlling the roll of the scope. So really try to get to past the pylorus, get a look at the papilla with just 2 fingers here going in and out. And if you can do that reliably, that you're going to really level up your endoscope skills to be ready to adopt endoluminal surgery techniques. And that's something you can do right now wherever you are in your training. Where can I get into a practice with EB? Hopefully, when we have a good insurance coverage, it's going to open it up to all sorts of places. But generally, the most reliable thing is if you have a place that does endobariatrics, a good chance you'll be able to do endobariatrics at that practice when you go land there. Potentially academics is a good place. Like, they're usually, there's more bureaucracy. The other guys can kind of attest to that. I have minimal bureaucracy at my place, which has an ambulatory surgery center, but it is more challenging just because you're working in, the reimbursement piece is just a little bit different. So, and then how do I get good? After you're like, okay, I really want to do endobariatrics, do lots of endoscopy, go to as many EB courses as you can, and film. Like, I cannot emphasize enough for film. Like, I watched so much film before I did my first endobariatrics. I still try to watch film. And it really, if you like, Galvao is on, Manuel is on websurge.com. I watched his videos with Silvana Peretta. Like, I'm pretty sure my wife could do an ESG. She's watched so many ESG videos with me. So YouTube and websurge.com, websurge with ERCAD are just great resources to get better. So I always like to, especially when you're out there and it's scary. It's scary when you're starting new stuff. And I remember how scary it was when I was getting going too. And I just remember this quote from Michael Jordan. I watched The Last Dance one weekend. And after that, I was like, oh my God, you know what? I'm not going to be scared anymore, because, just sometimes it doesn't always go the way you want it to, but you just keep getting better, and it is the reason why you succeed. So thank you all.
Thank you very much, Brandon, for this amazing presentation, always inspirational. And it's just incredible to see how much respect the faculty have for each other, how much we have learned from each other. It's a beautiful thing, and you can see that at SAGES. And that's why I encourage everyone to become members of SAGES and to tell your colleagues and friends about SAGES membership. So thank you, Brandon. A quick question for you, and thank you for the presentation. When you teach ESG, you already gave us the secret on how to train for it. And I think it's a precious piece of advice, what you said about doing everything with one hand so that the other hand is occupied for the more advanced therapeutic options. But how many of these do you think it would take someone to master that learning curve? I know it's different for everyone, but how many do you think?
After 10, you feel like, you're not going to throw up before every single one. So I would say it goes 10, 25, and then 25, and then 50, 50, 50, 50. Like, after about 10, you're like, okay, wow, I feel like I can actually do this. I don't feel like I'm completely browning out, like on all the different aspects. You start really appreciating more of the nuance. By 25, you're like, okay, I feel like I've gotten noticeably better. By 25, you feel like you've gotten much better again. And then by 50, you're improving from there. I think we're going to get everyone that's listening to this who wants to do it and isn't doing it now. I think we can get them on a much faster learning curve now. I started during COVID. Like, I didn't have proctors. Like, I would not recommend that. There's a lot of things. I remember at case like 48 or 50, I was having Chris McGowan. Like, I just have FaceTimed and was like, Chris, how do you do this or this? What are your questions? He's like, no, you just do this. And I was like, oh my gosh, I wish I would have had someone tell me this like 40 cases ago, So it's a really cool procedure. The ESG is a very cool procedure. I think it's one of the more challenging procedures that I do. I'd say it's even maybe more challenging than doing gastric bypasses, but sometimes, but it's more safe in a way, which is nice. But it's such an art. It's such an art, and it's so satisfying and rewarding to do well. So
it is an art. That's beautiful, and I thank you very much. And now we only have one question before we close. We're 2 minutes away from it, and any of the faculty could answer that. Brandon, of course, you're welcome to. Is there any impact of ESG on GERD? And what is your approach to ESG for a patient with a hiatal hernia who is not eligible for laparoscopic metabolic bariatric surgery? Tough one. Go ahead, please.
Great question. So very, very rarely does ESG make GERD worse, which is weird. It's very weird. I don't really have a great explanation for it. Some people have theorized it's the fundal part, but I generally actually go up into the fundus. I take as much of it as I possibly can. I still don't have a problem with GERD. It's weird. I don't know why they don't have GERD, but the ESG is by far the lowest drama of all the procedures. Like, the only complaint I've generally hear at year 2, 1, 2, 3, whatever is like, especially after 2, 3, 4, maybe it's just not quite working as well because it's stretched out than the other procedure than it was initially.
Yeah,
but
I could piggyback on that. I think even though the official like textbook recommendation and what most GIs do is not suture way up into the fundus. We go a short distance, but the majority of the fundus is left intact. And I don't think we'll have time to argue why, but I think even if you suture it down, I do think that there is going to be some accommodation or relaxation, and that's okay. And I tell patients this is going to stretch out, but that doesn't mean the effect's not going to stay there. And I think because of that, it creates a reservoir where the acid raft can sit instead of getting pushed up into the esophagus.
Thank you. And then one last part, the second part of the question, very, very quickly. Second, what is your approach to ESG for a patient with a hiatal hernia who is not eligible for whatever reason for metabolic bariatric surgery?
Yeah. So I had a patient that was like that. Really wanted an ESG, didn't want bariatric surgery. I went down about 4 centimeter hiatal hernia. I bailed. And I said, I don't think we should do this. I think we should repair this hiatal hernia first. He kind of just went into floated around for a while. And I ended up talking to several people, and they're like, you know what? I've been doing these with even 4, maybe close to 5 sometimes centimeter hiatal hernias, and they just seem to like reduce. And it's really weird. And I was like, all right, let's do it. And I do see it on smaller hiatal hernias. You see that when it really collapses that stomach, it does get smaller and it reduces the hiatal hernia part. It doesn't fix the cur, of course. Like, there's nothing you do about the cur there. But I ended up bringing him back later. I was like, hey, I think we could do this. And we did it. And he did great. It really benefited him. So yeah, I wouldn't, as long as it's under like under 5 centimeters, I wouldn't really hesitate. Yeah. Right. I mean, I would maybe, think about it and weigh all the options, but yeah.
So it was almost like a staged approach. First the ESG, and later on you did the laparoscopic hiatal hernia.
I didn't do the hiatal hernia at all. Yeah.
Oh, nothing at all.
Never. Yeah. No.
Right.
Yeah, and his heartburn got better and his weight got better. So
good. Well, thank you very much, Manuel and Adarsh and Brandon. Thank you so much, Micaela. I see that you returned for your probably in the OR. It's been a pleasure to have everyone here. I think we're right on time to finish. Any last minute words for everybody?
Well, thanks again for the invitation, and pleasure to be a part of this group and to meet with all of you again. Hope to see you again soon.
Yeah, thank you honestly for inviting us on. So it's very nice.
Thank you. Thank you very much, everyone. On behalf of SAGES and the RAF committee, it's been a pleasure. We look forward to seeing you again at the next webinar series. And thank you especially to Betty Muliguera, who is the senior coordinator for SAGES, helping us with the RAF committee. And thank you so much, Betty, for organizing this webinar. Our gratitude goes to you. Thanks.
Thank you.
Have a good evening, everybody.